All right, let's talk about Chapter 13, Vital Signs and Monitoring Devices. All right, we'll talk about gathering vital signs, how we're going to do that. We'll talk about what the vital signs are themselves that we gather. All right, importance of vital signs. These are outward signs of what's going on inside the body, okay? They identify important conditions or trends in the patient's conditions, and they're gathered on virtually every EMS patient. Now, we won't always get every vital sign from every patient. Sometimes it's a mental status and a skin condition. There's just certain situations where we won't get all of them, but our goal is to try to get as many of them as we can, all right? Patient severity and treatment priorities may prevent acquisition. So you may be managing somebody's airway or doing CPR or things of that nature, and you're not gathering all of the vital signs, okay? So what are the vital signs that we take? Pulse. So we're measuring their heartbeat, right? Their heart rate. Respiration, we're going to get a rate and a quality. Skin condition, skin color, temperature, condition, plus capillary refill, as we talked about in previous sections. Capillary refill is usually used on pediatric patients. Okay, we're going to check their pupils and we're going to check their blood pressure. Okay, now one thing on pulse and respiration. All right, anytime we give a rate, now we can teach you guys how to do the math real quick, and you'll get a heart rate of 80, just for example. Okay, anytime you give a rate, and this goes for respirations as well, but anytime you give a rate, you must give a quality as well. So you're going to say their heart rate is 80 and regular, or it's weak, whatever the case is. Okay, it's very important to always give a quality when you give a rate. Respirations, for example, respirations are measured in normal respiration rate for an adult is 12 to 20. Okay, but when we give that rate, we also want to give a quality. So their respirations are 12 and labored, or they're 12 and normal, or they're 20 and shallow. Okay, every time we give a rate, we have to give a quality. It's very, very, very important. Okay, baseline vital signs. Okay, this will be a test question. Make sure you know the definition of baseline vital signs. Okay, it's the first vital signs obtained. We call it the baseline because it's the first, but it's a very important set of vital signs we get, because at that point we can establish a trend. So if right now I take your blood pressure and it's normal, later on, 5 or 10 minutes later, I check it again and it's changed significantly, that can be a major indicator that something serious is going on with this patient, okay? All right, and then so that was our baseline, and then we get on to our repeat vital signs, and we gain further information by establishing trends, okay? On a stable patient, that means there's nothing very critical going on, there's no issues with the ABCs, we're going to reassess the patient every 15 minutes. And these will be test questions as well. So stable patient, we reassess vital signs every 15 minutes, okay? On an unstable patient, so something serious is going on with this patient, we need to reassess every 5 minutes. So make sure you guys know that, 5 and 15 minutes. Okay, what is a pulse? Palpable pressure of the heart beating, causing blood to move through the arteries in waves. Okay, as your heart beats, we are counting that, and you can do it for 10 seconds and divide that number by, times that number by 6. Or you can do it by 20 seconds and times it by 3. You can hold a pulse and count every heart rate for every beat for 60 seconds if you want, and that'll give you your pulse, your heart rate. Okay, it's kind of up to you. It's more accurate the longer you hold it. Me personally, usually I'll hold it for 30 seconds and times that number by 2 because it's nice and easy. All right. Pulse can be felt by placing fingertip over the artery where it lies close to the body's surface and crosses over a bone. The most common place that we were going to take a pulse from somebody would be their radial pulse. So if you feel right now, feel down your wrist, and on your thumb side, where the bone meets the wrist, okay, you feel down right along that bone, you're going to feel your radial pulse. All right. That's the most common place that we're going to take a pulse. You can take them at the carotid, which is in your neck. We'll show you guys how to do that when we get to the skills section. But if you want to feel right into your neck, on either side of your neck, you're going to feel your carotid pulse. You can check a femoral artery. That's right where your thigh meets your pelvis. And again, we'll show you how to do these things. Most common is the radius, radial pulse, and then the carotid, of course, for our unresponsive patients. There's a picture of someone checking pulse rate. He's counting for 30 seconds and multiplying by 2. Again, I find that's the easiest way. If you're real good off the cuff with math, you can do it differently. Okay, the pulse rate is the number of beats per minute. The normal rate for an adult at rest is between 60 and 100. A couple of definitions for you. You guys definitely need to know what these are. Okay, tachycardia and bradycardia. Tachy means fast. Brady means slow. So anything above 100 is considered tachycardia. Now, if a patient just ran a marathon, whatever the case is, maybe you're responding to a domestic incident and they're fighting with their spouse, whatever the case is, there are times your heart rate's going to be above 100 and it's not necessarily something to be concerned about. Okay. But if their resting heart rate is way above 100, these are things we really need to be worried about. And bradycardia, of course, being less than 60 beats per minute. Okay. Above 120 beats or below 50 beats per minute is considered a serious finding. Okay. During an emergency, it is not unusual for a pulse rate to be temporarily between 100 and 140. Okay. And these are a little bit subjective numbers. Everybody's a little different. They all react differently. But these are just kind of generalized indications that we can look for. Again, if there's a reason for their heart to be above 120, maybe not be concerned about it, but say, all right, well, let's give you 5 minutes and we're going to check it again. Make sure it comes down. Okay. Something for you guys to think about: what normal situations might account for a heart rate outside of a normal range. We just kind of talked about that. All right, quality. 2 factors determine the pulse quality. Okay, the rhythm. Okay, reflects regularity. Regular when intervals between beats are constant. That's irregular when intervals are not constant. Okay, so on our paper PCRs, and I don't know what you guys have, most people have gone to electronic charts at this point, but on the paper PCRs at least, there is a spot in the pulse section of the vital signs where you can say their pulse rate is 80, and then right underneath that there's a couple of bubbles that you can fill in. One's regular, one's irregular. That's why it's very important. We don't just throw the pulse ox on the patient and write the number down. Okay, as I said in the last section, they are tools. They're great tools, but we always have to take a manual pulse as well. So if you put that pulse ox on their finger, great. Also feel their pulse. Feel it. You're checking the machine to make sure that it's reflecting the right number. And 2, you're checking to see if that pulse is regular or irregular. Now, if somebody has AFib, for example, atrial fibrillation, and they have a different heart rhythm where it's not a constant boom, 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 okay? They might be bouncing around a little bit. That pulse oximeter is not going to read that correctly, and it's going because it's based on every beat that it picks up between 2 beats, and it constantly changes the number based on that. So if somebody has a skipping heartbeat for some reason, then that machine's going to read that incorrectly. So be aware of that as well. But we always have to take a quality with the rate. Okay. So our 2 factors that determine the quality, we already talked about rhythm. So is it regular, is it irregular? But we're also feeling for a force. Okay. Which is the pressure of the pulse wave as it expands the artery. Pulse should feel strong. It should feel strong. It should feel constant. A normal rhythm, I should say. Okay. When it's weak, that's something to note. Okay. They might have a normal heart rate, but it's weak. And that is an indicator we might have some cardiac issues going on. Okay, common pulse locations. We talked about the radial, all right, the radial pulse already. We will show you guys how to do this stuff when we get together for skills on this. Brachial, that's one I didn't mention. The brachial artery, this is generally used in younger patients, a little easier to get on the pediatrics, but it's right up on the inner part of your bicep. So if you feel above your elbow, right underneath your bicep on either arm, you should be able to feel a pulse there. And that is the brachial pulse. There's an example right there. Okay. All right, common pulse locations, the carotid we talked about. Assessing the pulse, count pulsations for 30 seconds and then multiply by 2. Again, that's the easiest way. You don't have to do it that way. But if you do it for 15 seconds and times it by 4, you might not be able to figure out, well, I got 17. What's 17 times 4? Okay, that's where it can get complicated. It doesn't hurt to just hold on for 30 seconds and just count it, times it by 2. All right. If the rate, rhythm, or force are not normal, continue with a count for 30 seconds. That's a recommendation. If you feel something's a little bit off, hold it a little longer. Go for 60 seconds. That's okay. All right, respirations. With regard to vital signs, respiration means the act of breathing in and out. All right. Measurement includes both rate and quality. Again, the quality, I know I focused on this a couple slides ago. It's very important to get the quality with the rate. Okay. And that's not just breathing in, that's breathing out. Breathing in, breathing out, that's 1. Okay. That's the number of the breaths patient takes in 1 minute. And rate is classified as normal, rapid, or slow. Like I said, you could add labored into that. It means they're having real trouble tugging. Shallow is another one. They're breathing the right rate, but they're really shallow. They're not moving a lot of air. Okay. Normal rate for an adult at rest is between 18 and 20 breaths per minute. The age, sex, size, physical conditioning, emotional state all influence the breathing rates. We'll talk about pediatric vital signs at a later section when we get to lifespan. The younger you are, the vital signs change, the normal, if you will, vital signs change some. We don't need to memorize those necessarily. We just have to know that they are different. And it wouldn't hurt to have a cheat sheet in your ambulance. We have these little cards, pediatric vital signs cards that are really helpful to see what's normal for a kid that age. All right, rates above 24 breaths per minute are considered rapid, or below 8 breaths per minute are potentially serious findings. I want you to change that in your head, that 8, I want you to change that to 10. Okay, if we get below 10 respirations per minute, that is potentially serious. I will tell you a quick story. When I took this class 9 years ago, my patient, when I did my practical skills exam, she was actually breathing 8 times per minute. And I said to the proctor, I'm like, well, I should be bagging her. And he liked that answer. He wanted that answer. But in real life, this patient just normally breathes slow. She was healthy, physically fit. A lot of times her respirations are lower. So just because they're, 8 or 9 or 10 or whatever respirations per minute doesn't necessarily mean that's a 100% indicator that we need to bag them. But we also have to look at the inadequate respirations. If we think that if they're cyanotic, if they're cool and clammy, and they have some other things going on, then yes, absolutely. But if the person's, skin is warm, pink, and dry and normal, no signs of inadequate breathing, just because they're breathing 8 or 10 times per minute doesn't necessarily mean to just start pushing air into their lungs. Okay, hope that makes sense. Respiration quality. Again, there's categories. We want to see their respirations are 16 and normal, or 16 and regular, shallow, labored, noisy. Okay, we always want to get lung sounds with these too, so we can. We'll teach you guys how to do that. Right. Respiratory rhythm. Count the respirations after assessing the pulse rate. Okay, generally speaking, count number of breaths taken over 30 seconds and multiply 2. It's the easiest way to do it. Again, you don't have to. You can do 20 seconds and times by 3, but it gets a little complicated that way. I highly recommend just doing 30 times 2. Skin condition. Okay, so we have talked about the pulse rate. We've talked about the respiratory rate. Skin condition is another vital sign. Okay, the color, temperature, and condition of the skin can provide valuable information regarding circulation. When you get your skills sheets, you will see in part of your primary assessment is assessing the skin condition on your patient. Okay, the skin can be a valuable tool for telling you what's going on inside the body. Okay, so we're looking at color. Okay, the best places to assess skin color: nail beds, inside the cheek, inside the lower eyelids. Okay, we're talking about people with darker skin, African Americans, and that. If you can't get a good skin condition, you can look at these different places. All right, we're looking for abnormal skin colors. Okay, so what exactly are we looking for when we're talking about the color of the skin? Anything abnormal. Okay, warm, pink, and dry we consider is a normal skin condition. But abnormal, we could see pale skin, we could see cyanotic, which would be bluish, grayish. You know, that's saying we're not getting enough oxygen. Could be flushed and red, or jaundice and yellow. Jaundice would indicate some kind of kidney problem. A lot of times you can see that in the eyes, where the whites of their eyes are real yellow. That's considered jaundice. And then the temperature of the skin too. All right. So feel a patient's skin with the back of your hand. Note if the skin feels normal, warm, hot, cool, or cold. Now, when we're taking a pulse, we're touching their skin, right? So that's the perfect opportunity to note their skin condition as well. Okay, we don't need to take a pulse for 30 seconds times by 2 and then go back and feel their skin again. We just did. All right, so this is a good opportunity to do both. Now, yeah, you can feel their forehead if you want, but we don't really put our bare skin on other people's bare skin unless we really needed to. All right, pediatric note for children under 6, we should also be evaluating the capillary refill. Nothing says that we're required to take that as a vital sign, but it is a helpful tool, as I've said in other sections. All right, so you press on the nail bed on the top of the hand or foot and release. Observe how long it takes for the normal pink color to return. Okay, normal is less than 2 seconds. All right, if it takes 5-6 seconds for that nail bed to fill back in with color, then we know that something is probably going on. Okay, pupils. We'll talk again. All this stuff, I know it's hard in this format to just listen to me talk and look at these PowerPoints and try to understand what I'm talking about. I want to try to give you the principles, but when we get together to teach these sections in person, we will actually demonstrate taking the whole full set of vital signs. We'll show you guys how to do it, and then you'll do it on each other, okay? But we're looking at the pupils, and this is one of our vital signs, okay? And we're talking about the black center part of the eye, okay? If we dim the environment, the pupil will dilate, okay? So if we turn the lights down, turn the lights off even, all right, your pupils are gonna get big because it's letting more light in so you can see, okay? We turn the lights on or turn the lights up, the pupils will constrict, meaning they'll get smaller, okay? And how we check this is usually we'll dim the lights in the ambulance so your eyes will normally dilate. And then we take a really bright pen light and we watch the eyes and we shine that bright light into their eyes, and they should shrink, okay? And they should shrink evenly. So if I put that bright light into your right eye, your left eye should constrict as well. So that's what we're looking for when we check pupils. Now, if you see, yes, this right eye constricts, gets small, and the left eye doesn't, okay, that could be an indicator it's a head injury. Something could be going on. It could be a stroke, things like that. So they should dilate and constrict evenly, even when the light's not put into that other eye. Okay, note the baseline size, roughly. Okay, cover one eye and shine a light into the other eye, and then repeat with the other eye. Again, you can cover the one eye when you check the first eye, but we want to see both eyes constrict and dilate at the same time. Okay, here's an example of pen light right there. See his pupils are kind of constricted, and they should be constricting and dilating evenly. Oops. Okay. All right, so we're looking for size, equality, and reactivity. How big are they? Are they moving with each other? Okay, how quickly are they moving? Here's an example right here. So constricted pupils, see how small that looks in the top there? All right, dilated on the bottom, they look a lot bigger. And then unequal. So we want them to be equal. Now it looks like they shine the pen light into the right eye of this guy on the bottom, but the left eye is not reacting, okay? And we will classify this as, with a normal set of pupils, we will say they're pearl, okay? Pupils are equal and reactive to light. So when somebody says, how are their pupils, you can say they're pearl, and people are gonna know what you're talking about. Okay, unequal pupils can be a sign of the influence of a topical drug. I've never seen this in drugs myself, but that is something that could be going on. I would be more concerned about head injury or stroke. Okay, blood pressure, okay? Blood pressure is the force of blood against the walls of the blood vessels, okay? Normal, again, these are normal adult vital signs, okay? We want to see 120 over 80. Systolic is the top number. We want that no greater than 80 millimeters of mercury, and that's the unit of measurement we use for this. Diastolic no greater than 80. Change can indicate something very significant. When we talk about shock a little bit, we talked about shock in the last section, and we'll beat this into your guys' heads pretty good. One of the major indicators that somebody's in shock is high heart rate and a low blood pressure. Okay, so if we get a 120 over 80 after a car accident now, great. If 10 minutes later, their blood pressure's down to 90 over 40, that's not good. Okay, it's measured with a sphygmomanometer. You guys are going to have to learn how to say that. Sphygmomanometer. That is the blood pressure cuff and a stethoscope, okay? Cuff should cover 2/3 of the upper arm, elbow to shoulder, okay? We're going to put the blood pressure cuff on like so. See that little needle in the middle? See how it's pointing straight down? If you guys see that kind of oval, looks like a zero, but it's like a wide zero, okay? Your stethoscope, if that needle at no pressure is outside of that line, that oval there, that means that your blood pressure cuff is not calibrated properly. And there is a tool to fix that and adjust it. But you're not going to get an accurate blood pressure with that cuff. So always look at it before you put it on the patient. As long as it's down in that little zero mark, you're great. If not, grab a different cuff and then get this one fixed or replace it. I mean, they're pretty cheap to replace anyways. All right, blood pressure, again, is measured with a sphygmomanometer and a stethoscope. Wrap the cuff around the patient's upper arm. Lower edge of the cuff is placed about 1 inch above the crease of the elbow. Center of the bladder placed over the brachial artery. So again, I'll go back to this other picture here. They have little arrows, and we want the arrows to be pointed pretty much down at the artery, okay? If we spin this cuff so far that the dial is on the outside of the arm, the bladder is not going to be in the right place, and you're not going to get an accurate blood pressure. Sometimes it's hard to do, so we can cheat it a little bit to the left so that we can see it better, but don't go too far, okay? Just a little bit is okay, but don't spin it around backwards. All right, center of the bladder placed over the brachial artery. Okay, prepare the patient. Just let them know, hey, we're going to squeeze your arm. Okay, and it's also actually very appropriate for us to say, is it okay to take a blood pressure on this arm? Women who have had a mastectomy and people who are on dialysis, they can't take a blood pressure on that side of that arm. And these patients know. They know that they can't do it on that arm. So if you say, is it okay to take a blood pressure on this arm? Sometimes they'll say, oh, no, I have an AV fistula, which we'll learn about later. But you can't take it on my left arm. You're gonna have to take it on my right arm. No problem. We'll take it on the arm that you want, okay? So position the cuff and the stethoscope. Palpate the brachial artery at the crease of the elbow, okay? Position the stethoscope. Position the diaphragm of the stethoscope directly over the brachial artery or medial anterior elbow. Okay. Generally speaking, we don't palpate the brachial artery when we do a blood pressure. But we're going to get our stethoscope ready. We're going to get our blood pressure cuff in the right place. And we don't need to overthink this either. It's a very simple process to do it. I know there's a lot of steps that we're listing here. All right. All right, we're going to inflate the cuff. So now we're going to start squeezing the bulb. And we're going to listen and inflate until the gauge reads 30 higher than the point the pulse sound disappears. So now we're listening with our stethoscope. We're hearing the pulse, okay? We want to squeeze that cuff until we don't hear a pulse anymore. We're actually cutting off circulation in that arm temporarily. All right, so we go up a little bit past it where we stop hearing it, and then we slowly release the air from the cuff. There's a little dial on the side of the bulb. We slowly release it. And you're watching the needle as it comes down. Now, as soon as you hear that pulse again that we just cut off, that's your systolic number, okay? Now, to obtain the diastolic, again, the systolic was the top number. That's the high number. Now we're going to get the lower number. Okay, we're going to continue to deflate the cuff. So let the needle keep coming down. Let the air out. When the sound turns to dull, muffled thuds, the reading on the gauge is the diastolic pressure. Okay, we're going to stop hearing a pulse at a certain point, which is what this comes down to. So again, I'll just recap. We're going to squeeze the cuff, and we're going to be listening for a pulse. We're going to hear it as we're squeezing. And as soon as you stop hearing it, go up, give it another squeeze or two, and then slowly release the valve. And as that air is coming down, you're watching the needle on the gauge. And as soon as you hear the pulse again, that's your top number, okay? Continue listening as the needle comes down. And then as soon as you stop hearing the heart rate again, that's your bottom number, okay? And then record your measurements. Usually what I do is I write them on my glove. Some people like that, some people don't. Some people like to have a little notebook. I find it easy to just write on the back of my my non-dominant hand, and a time. You want to write the time you took the vital signs as well. All right, determining the blood pressure by palpation. This is something we don't do very often, but it is a tool that we can get their blood pressure this way. It's usually when you are in a really loud environment and you just can't hear it. You just can't hear them talking, you can't hear the pulse. All right, but we can get half a blood pressure anyways. We can get the systolic number, which is the top one. So I'll just tell you real quick how to do that. All right, so now we're gonna feel for a pulse. We're gonna palpate, which is feel. We're gonna find that radial pulse. All right, you're gonna inflate the cuff. So you're gonna start squeezing, all right? And we're gonna go up a ways, and we're not gonna hear the pulse, or we're not gonna feel the pulse anymore. Then we're gonna let the needle down, let the pressure off. And as the needle's coming down, as soon as you start to feel the pulse again, that's your systolic number. Now, we can't get a diastolic this way, but we can at least get the top number, and that's an important number to get. Pediatric note: difficult to obtain on infants and children younger than 3 years old. More useful information about the condition of an infant or very young child comes from observing for conditions such as sick appearance, respiratory distress, or unconsciousness. Talking to the parents, like what do they normally act like? All right, certain things like that when pediatrics. The hospital does not expect us to obtain blood pressure on anyone less than 3 years old anyways. So if you have an infant, you might as well, if you have time, you can try. You can get it on their leg. It's not easy to do with a stethoscope. I would just say don't even worry about it. Some of the machines, the life packs and stuff, they'll wrap it around the child's thigh, and it can get a blood pressure, but it's not easy to do manually. Determining blood pressure by blood pressure monitor. So you got these $40,000 life packs that are in some of your ambulances. They're kind of nice, but again, they're a high quality tool, but they're still a tool. We should always be taking at least one manual if we have a monitor. Okay, but we put the cuff on, we push the button, it inflates, and it tells you what the blood pressure is. Okay, but a lot of movement will screw up those machines too. So you might get a number that looks way off. You're like, I don't know if I believe that. Check it manually. Check it manually because those machines can get a false reading. Okay. All right, temperature. We really don't check the temperature. It's not really part of our protocols to check the temperature of our patients. So we don't carry around thermometers. On this day of COVID right now, it probably wouldn't be a bad thing, but it's not part of our protocol, so we don't generally check temperatures. So I'm not going to get into that. All right, and just, temperature varies throughout the day based on your age. I mean, usually I run low. This lady's 98. I usually run the 97s. Oxygen saturation. So this is where we use our pulse oximeter. It is considered one of our vital signs to get an oxygen saturation. It's the measurement of proportion of oxygen attached to the hemoglobin. And it's measured with a pulse oximeter, okay? It's a fancy little tool. It measures the amount of oxygen in the blood, and it gives you a number in percent. Okay, we should be seeing 95% or higher. 100 is great. 96 is fine. If they start getting below 95, we need to start considering giving them supplemental oxygen. All right. Protocol depends on the institution. Okay, we're all in the same region. Our protocols are all the same. If they're below 95, we need to be giving oxygen. Okay. But again, these are tools. These pulse oximeters are tools. They're great tools, but sometimes they'll malfunction. If somebody has thick nail polish on, you might not get an accurate reading. You can try to turn the pulse oximeter sideways on the finger, and that might help. Get a better reading on kids. You can put it on their toes, little babies. You can try to put it on their toe because they generally speaking, you put it on their finger, they don't really like that and pull it off. All right, that's an option for you. Generally includes all patients complaining of respiratory problems or otherwise at risk for hypoxia. I mean, anymore, those pulse oximeters are kind of cheap. We just put them on all the patients just to get that. Here's an example of a pulse oximeter. See that percent SpO2. All right, that's the oxygen saturation reading, and this person is at 98%. And then their heart rate is below that, that's 82. But we could say, oh, look, their heart rate's 82, but it's 82 and what? We have to give their rate. So that's why it's appropriate for us to feel the pulse as well. Okay, interpreting readings. I don't want to get too much into this, but again, 95. If it's below 95, we need to be putting them on oxygen per our protocols, okay? Accuracy can be affected by shock and hypothermia. Carbon monoxide, that's another one. So our firefighters go into a smoky fire, don't put their CBA on, and they inhale a whole bunch of carbon monoxide. They come out, get their vital signs checked. Oh, they're 100%. Well, carbon monoxide actually attaches to the hemoglobin in your body better than oxygen does, and it blocks it. So you could be suffocating on the inside because the oxygen molecules are blocked. They can't attach to the blood. So a pulse oximeter reading is going to say 100%, but a lot of that could be carbon monoxide. That could be very serious. So that's why we need to understand carbon monoxide poisoning and what those signs and symptoms are, which of course we'll get into in a later section. Some real fancy pulse oximeters, they have an SpCO rating on them. And that can actually differentiate between the two, and it can say how high your carbon monoxide levels are. Now, most of us, especially smokers, but anybody really has a certain amount of carbon monoxide running through their blood at any time. I think don't quote me on the exact numbers, but I think if it's like below 8 on the SpCO, it's considered normal. A smoker can get up to like 11 or 12. So point is, don't quote me exactly on those numbers. The point is we all have a little bit of carbon monoxide running around in our bodies at any point. But those SpCO meters, if we put them on somebody who came out of a smoky fire and it's reading 25, that's serious. And really the only way to clean out your system before you die is to go to a hyperbaric chamber. And the closest one is in Pittsburgh, I believe. So they'd have to fly you to Pittsburgh and put you in this oxygen room, basically. It might actually be a tube. I've never seen one before, but they just pump you full of oxygen all day long, and you could be there for days just in this environment to get the carbon monoxide out. Okay. The accuracy of reading, sorry, I went on a tangent there. Certain other uncommon types of poisoning can affect it. Excessive movement can mess with your pulse ox reading, and nail polish, anemia. Okay, blood glucose meters. So once you get out of this class, you will have to credentialize on glucometry. And that's just where once a year you pull out the glucometer and you make sure you remember how to use it. But these are meters that will measure the blood, the glucose in your bloodstream. And a lot of times, any altered mental status patient that you see, we should be checking his sugar. Even if they don't have a diabetic history, we can just poke them real quick. It's pretty harmless. There's a whole procedure on how to do it. We will demonstrate for you. But this is a very important number to get, especially on the diabetic history patients, but very much so on any altered mental status patient. Okay. Using a blood glucose meter, permission from medical direction or by local protocol is required to perform blood glucose monitoring. Okay. Meaning our medical directors have to say it's okay for us to do it, and they do say it's okay for us to use it. However, they do want us to credentialize on it every year. Okay, real quick on how it works. Prepare the device, test strip, and lance it. So we put this little test strip inside the machine, and that turns it on. Okay, we clean the patient's finger with alcohol. We poke the patient with these tiny little lancet. We put the blood onto the test strip that's already in the machine, and the reading will be shown on the machine. Now, I don't like this slide. I don't like to get into normals when we talk about glucometry. Everybody is a little bit different. So generally speaking, if you have a patient who's altered mental and their blood sugar is in the 60s or below 60, it's probably why they're altered, okay? We shouldn't be seeing readings any more than 120 to 140, okay? Again, everybody's a little different, especially those with diabetes. They run at different levels than a normal, I'm using quotation marks, a normal person. So again, don't get too hung up on the normal numbers, but we'll talk more about this when we get to the altered mental status and diabetic section. Okay, pediatric note, age is one of the most important factors determining normal range. Okay, again, everybody's a little bit different. Infants and children have faster pulse and respiratory rates and lower blood pressures than adults. When we're talking about vital signs, like I said, the kids, the younger they are, the more different their vital signs are from a normal adult. Okay, so they have faster pulses, faster respiratory rates, and lower blood pressures than adults. So everything kind of comes together as you age, but we should be aware of that. And again, you don't need to memorize the vital signs for kids, but just know that they're a little bit different. We're going to be focusing on normal adult vital signs in this class. Okay, quick review. You can obtain a great deal of information about a patient's condition by taking a complete set of baseline vital signs, including pulse, respiration, skin pupils, and blood pressure. Okay. Again, the baseline is very important because that's going to establish your trend, especially if you have a long transport. Get that vital sign, set of vital signs early on, and then monitor it throughout the call. And if there's major variations, you got to let the hospital know that. Okay. The EMT must become familiar with normal ranges for pulse, respirations, and blood pressures in adults and children. Okay. Again, more so adults. We're going to focus on here. Trends in patient's condition will become apparent only when vital signs are repeated, an important step in continuing assessment. How often you repeat the vital signs will depend on the patient's condition, at least every 15 minutes for stable patients. We talked about this earlier on. Again, 15 and 5 minutes are your key numbers. So we're going to ask you throughout class, okay, this is your patient. How often do you reassess? And you're going to say, well, that patient's not stable. We're going to reassess him every 5 minutes, okay? Or that person is stable. We're going to reassess every 5 minutes. It's part of your testing, okay? Remember, consider there is time to obtain vital signs, or if you must wait and obtain them en route to the hospital. If there is time to obtain vital signs, you do your best to get that set of vital signs early on, but don't walk right up to your patient with a blood pressure cuff. You gotta do your primary assessment first, which is your ABC stuff, which we haven't really got too much into yet, I know. But getting vital signs early on is very important, okay? Consider when to use a pulse oximeter. Should you apply it to a patient with difficulty breathing or without difficulty breathing? I would say yes. It's kind of a simple question. It's a non-invasive tool that we have. Just stick it on their finger, stick it on everybody's finger. It doesn't hurt. All right. Consider whether abnormal vital signs are a result of an injury or an illness or some type of factor. Okay, questions for you guys to consider. Okay, name the vital signs. Which vital signs are we taking? Why should they be taken more than once? How much time should the EMT spend looking for a pulse when the radial pulse is absent or extremely weak? That's actually a pretty good question. If you can't, there are times where you have a really weak pulse and you have trouble finding it, and it's happened quite a few times throughout my career. If you really can't find that radial pulse, you should be checking for a carotid pulse. However, if the patient's sitting there talking to you, it's a little funny to just stick your fingers into their neck. You might want to explain to them what you're trying to do. Or really, it doesn't hurt to, if you have another EMT there with you, be like, hey, can you check and see if you can find a pulse on this person? They're sometimes tricky to find. How should you react when the blood pressure monitor gives a reading that is extremely different from a previous reading? Okay. So again, this is why we say that it's a fantastic tool, but it's a tool. Okay. You should definitely be checking manually. Okay. And if it's accurate, then you better note that and say, well, what's going on with this patient? Why their blood pressure just drop out so much? How can you get an accurate pulse oximeter reading on a patient with thick artificial nails? Well, like I talked about before, sometimes you can try to turn it sideways. You can try a toe on an adult. I mean, there's no reason that wouldn't work. When I was a volunteer with Kennedy, we would carry those little nail polish remover. They're like alcohol swabs in little packs, but there was nail polish remover, and we could clean people's nails off. Of course, some people spend a lot of money on their nails, so be aware of that. If you have to take their nail polish off, they might get mad at you, so you might want to explain to them what's going on. Sometimes the patient's heart will have an electrical problem and beat 100 to 200 times per minute. Why is the pulse so weak in a patient? It's just something for you guys to think about. All right, I would say it's beating so fast that it's not pre-filling, like we talked about in the last section. Okay, and that's the end of it, and I will get to work on the next section. See you guys soon.